Hello, in this video I'm going to talk about breast cancer. So a 65-year-old woman with no previous history of breast cancer was referred to the medical oncology clinic for newly diagnosed metastatic breast cancer. 3 months ago, she developed left breast pain and a palpable breast mass. Mammogram and ultrasound revealed a 5.2 centimeter left breast mass with an enlarged ipsilateral axillary lymph node. Core biopsy of the mass showed an invasive ductal carcinoma. Estrogen receptor was 95% positive and progesterone receptor was 85% positive. Fine needle aspiration of the axillary lymph node was positive for adenocarcinoma. Positron emission tomography or CT was obtained and it revealed 1 to 2 centimeter positron tomography avid pulmonary nodule and enlarged mediastinal and hilar lymph nodes suspicious for metastasis. Interventional radiology was consulted for core biopsy of one of the pulmonary nodules. The biopsy confirmed metastatic breast cancer. Estrogen receptor 95% positive, progesterone receptor 90% positive. So breast cancer general concept. So generally background, breast cancer is the most common malignancy affecting women worldwide. Globally, it accounts for 25% of all cancers in females and also causes the greatest number of cancer-related deaths among women. In 2018, it is estimated that 6,207,000 men, 100,000 women died from breast cancer. That is approximately 50% of all cancer deaths among women. In the USA, the incidence since 1982 has been risen by 4.5% per year. From World Health Organization Globocon, there were 1,677,000 new cases worldwide. That's 25% of all cancers, with 883,000 from less developed countries. Incident rates vary across the world, with rates ranging from 38 over 100,000 in West Africa, 96 over 100,000 in Western Europe. There were 522,000 deaths and more than 6.2 million women living with the disease in 2012. So, what are some of the risk factors of breast cancer? 1. Increasing age. 2. Family history, first degree relative, a sister or a mother. Nulliparity, early menarche, late menopause, late first pregnancy, oral contraceptive and hormone replacement therapy, previous history of breast cancer, previous history of endometrial cancer. So let me just stop there. So nulliparity, woman who has not given birth before, who has not had any gestation prior, who has not had any pregnancy up to 20 weeks of gestation. Early menarche. So one thing you have to know that or early patient who have early menarche and late menopause have been found to have increased levels of estrogen, and estrogen is a hormone that has been found to increase the risk of breast cancer. So late first pregnancy, when you get pregnant, estrogen levels drop and then progesterone levels rise. So during that estrogen levels has gone down, it is a protective factor. So having an early pregnancy is a protective factor against against breast cancer, and late first pregnancy it is a risk factor. And oral contraceptives, the contraceptives are estrogen contraceptive. Previous history of breast cancer, previous history of endometrial cancer. The reason being is that we have estrogen induced cancers. One is one is breast cancer. The second one is endometrial cancer. So if you have an endometrial cancer, you are at risk of developing breast cancer. Then we have the modifiable risk factor, that is diet and fat intake, smoking. Then we have BRCA1 and BRCA2 mutations are associated with multiple early onset of breast and ovarian cancer. BRCA1 and BRCA2 are genes that are found on our chromosomes, and mutations have been associated with these genes have been found to cause an early set of breast and ovarian cancer. So these are genes that are found on chromosome 17 and 13. So we have types of breast cancer. We have carcinoma in situ. What is carcinoma in situ? Carcinoma in situ is a type of cancer that is confined within the epithelium and has not metastasized to the adjacent cells. So types of carcinoma in situ: ductal carcinoma in situ, lobular carcinoma in situ, Paget's breast disease. Then we come to the invasive carcinomas: invasive ductal carcinoma, invasive lobular carcinoma, mucinous carcinoma, medullary carcinoma, papillary carcinoma, inflammatory carcinoma. So we go to TNM staging, staging of breast cancer. TNM staging is a system that is used in staging cancers. T stands for tumor, N stands for lymph node involvement, and M stands for distant metastasis. So as you can see, stage 1 is a tumor less than 2 centimeters in size with no lymph node involvement. Stage 2A, we have stage 2A. So we have a tumor within 2 to 5 centimeters and with no lymph node involvement, and a tumor less than 2 centimeters with mobile axillary lymph node. We have stage 2B, a tumor greater than 5 centimeters with no lymph node involvement, and a tumor less than within 2 to 5 centimeters with no with mobile lymph nodes. Then we go to stage 3A. Stage 3A, a tumor greater than 5 centimeters with mobile lymph node and a tumor less than 2 centimeters with fixed axillary lymph nodes within 2 to 5 centimeters with fixed axillary lymph node, greater than 5 centimeters with fixed axillary lymph node. All the metastases are stage 4. So metastases have all the metastases. So if it has metastasized to the pulmonary system, it's stage 4. It has metastasized to the bone and the spine, is stage 4. It has metastasized to the brain or liver, is stage 4. So what is some of the clinical presentation of breast cancer? Painless swelling. It is the most common presenting complaint. Skin changes, pallid orange, nodules or ulceration, changes in the nipple or areolar region, nipple retraction, blood stain discharge, axillary lymphadenopathy. So metastatic presentation. So if it has metastasized to the pulmonary system, there may be pulmonary symptoms such as cough, exertional dyspnea, hemoptysis, and so forth. Osseous deposit may cause bone pain, especially backache, paraplegia from cord compression, hepatomegaly and ascites from liver metastasis. Cerebral metastasis may present with headache, confusion, altered level of consciousness, convulsions, seizures, and syncope. What are some of the differential diagnoses? So differential diagnosis of breast cancer: fibroadenoma, benign mammary dysplasia, galactoscale, traumatic fat necrosis, chronic breast abscess, duct ectasia. So diagnosis of breast cancer requires triple assessment through one, clinical assessment, that's history and examination; imaging, that's radiological assessment and mammography; and histopathological assessments. The clinical examination. So the breast clinical examination, the breast may be bigger than the normal breast, or smaller from attachment of the tumor or underlying chest wall. There may be nipple retraction. There may be skin changes, that's pallid orange. Physical features will determine whether it's fibroadenoma, that's firm, mobile, definite edge; cyst, a soft, fluctuant edge; carcinoma, firm with indefinite edge. The axillary, cervical, and supravicular lymph nodes are palpated. If it's enlarged, the mobility, size, and consistency should be determined. The chest is then examined for pulmonary pathology or pleural effusion. So how do you examine the chest for pulmonary pathology or pleural effusion? So on inspection, you measure the respiratory rate. You check for any abnormal chest wall movement. You check for pectic excavatum, pectic carinatum. On palpation, you palpate You check for tactile fremitoes. Tactile fremitoes. You do your vocal resonance, and then if there is a consolidation, tactile fremitoes will be increased, and total fremitoes and vocal resonance will be increased. Percussion will be dull. If there is an effusion, percussion will be stony dull. Tactile fremitoes and vocal resonance will be decreased. Tactile fremitoes and vocal resonance will be decreased. Air entry may be decreased in consolidation. Air entry may be absent in effusion. So that's a little difference that you have to know. And the abdomen is examined for hepatomegaly. So when you are examining the abdomen on superficial examination, you examine for guarding and tenderness. On deep examination, you examine for masses. If there is an enlarged liver in normal healthy individuals, the livers cannot be palpated. But if it's enlarged, it can be palpated. And we all know the liver enlarges to the right iliac fossa. So you start your examination with deep palpation from the right iliac fossa and move your way up. And if there is an ascites, you do your shifting downwards. If there is ascites there too, ascites will be demonstrable by shifting downwards and a fluid trail. So that's what you have to. Let me repeat that one again. So on chest examination, on pulmonary examination, so air entry may be reduced or absent. May be reduced or absent. Percussion may be stout in consolidation, stony dull in effusion. Vocal resonance may be decreased on consolidation, and vocal resonance and tactile fremitoes may be increased on consolidation. It may be decreased on effusion. And hepatomegaly, to start out deep palpation from the right iliac fossa and move your way upwards. Ascites will be demonstrable by shifting downwards and a fluid trail. So do imaging, mammography, ultrasound of the breast. MRI is useful in determining distant metastasis. So if there you are suspecting a metastasis to the spine, you do an MRI of the spine. So cytology, fine needle as so cytology always when cytology is done, three things come to mind. Cytology biopsy, three things comes to mind. One is to confirm the diagnosis. Two is to establish or find the histological type of carcinoma or histological type of inflammation that has occurred. So it is the histological type of carcinoma. And the third one is to help in determining the best course of management, whether we have to do a chemotherapy, whether we do a radiotherapy or surgery. So these three things come to mind. So other useful investigation. So chest x-ray to determine metastasis of the lung, abdominal pelvic ultrasound. So one thing is that when you are doing an imaging, always be specific. You don't just say x-ray, just say chest x-ray. If it's an abdomen, if an x-ray of an abdomen, just say abdominal x-ray, supine and erect. Let anyone who is listening to you know what you are talking. So if it's the x-ray of the chest, just say chest x-ray, abdominal pelvic ultrasound, obstetric ultrasound, present it in that way. So abdominal pelvic ultrasound to determine hepatomegaly and ascites, x-ray of the spine, pelvis to determine bone metastasis, CT of the brain to determine cerebral spread. Others auxiliary investigation as indicated, full blood count, blood urea creatinine, liver function test, renal function test. Management, we have four sorts of management. So one is surgery, two is radiotherapy, three chemotherapy and hormonal therapy. So there are two forms of surgery that can be done in this case. One is breast conservation surgery. That's the local excision followed by radiotherapy. And two is total mastectomy. Then we want to do a little bit of preventive medicine here. So in breast cancer, what's the screening protocol for breast cancer? The test used to screen for breast cancer is mammography and manual breast examination. Mammography with or without clinical examination is recommended every 1 to 2 years from age 50 to 74. The American Cancer Society no longer recommends monthly self-breast examination as a screening tool. Patients with strong family history of breast cancer, that's first-degree relative, should consider prophylactic tamoxifen. Tamoxifen prevents breast cancer by 50% in those with more than one family history of breast cancer. So let me end with this case, and then we'll see how this patient will be managed. A 49-year-old woman presents to her primary care physician for a general checkup. She has not seen a primary care physician for the past 20 years, but states that she has been healthy during this time frame. She has had breast implant placed when she was 29 years old, but otherwise has not had any surgeries. She is concerned about her risk for breast cancer, given her friend was recently diagnosed. Her temperature is 36.1 degrees. Blood pressure is 114/64 millimeters of mercury. Pulse rate is 70 beats per minute. Respiratory rate is 12 breaths per minute or cycles per minute. Oxygen saturation 98% on room air. Physical examination is unremarkable. Which of the following is the most appropriate workup for breast cancer for which of the following is the most appropriate workup for breast cancer for this patient? So A, BRCA gene testing, 2, mammography, C, no intervention indicated at this time, D, sentinel node biopsy, E, ultrasound. So which of the following is the most appropriate step in managing this patient? The answer to this is C, no intervention indicated at this time. Why? Because women with implants should undergo breast cancer screening at the same time schedule as women without breast implant. Since this woman is 49 years of age, is 49 years, she is still not 50 years of age, and she has no risk factor or no family history of breast cancer. So there is the indication at this time, there is no intervention that is indicated at this time. But you have to tell her to return to the consulting room or breast clinic next year, because she's only 49, and after just a year to come she'll be 50. To return after when she's 50, she'll be qualified to go for mammography and screening, manual breast examination. So that's all for breast cancer. Make sure you check out the videos of the first video I did on breast examination and how to manage breast pain and nipple discharge, and a second video on common pathologies such as fibroadenoma, fibrocystic disease, and then breast cancer. Make sure you subscribe, and I hope you like the video. Thank you.